Hi everyone, I'm Dr. C Gupta, Clinical Director and Chief of Vascular Surgery and Department of Interventional Radiology and Podiatric Surgery at Care Hospital in Banjara Hills. So this is a truly multidisciplinary team that works together to deal with all vascular problems. And what better to discuss today with Dr. Pradeep, who's the Director of Interventional Radiology in our team, than vascular malformations, which truly require a multidisciplinary approach. So, Dr. Pradeep, can you explain to us what are vascular malformations? How do they differ from vascular tumors?
I mean, say in one word, vascular malformations are like the arteries, veins, and lymphatics gone haywire. They kind of join where they should not join, and they are more in number where they should not be more. Hamartoma is something similarly applied to these lesions as well. And tumors are basically, in some sense, abnormal multiplication of the vessels.
Yeah.
So
Okay.
I think I'm assuming you are asking this question because there is always this confusion between a hemangioma and a vascular
Yes, you
malformation.
got it right. Because we see so many patients who come with vascular malformations, they have an image and the report given is hemangioma.
True.
Whereas we know it is not a hemangioma. So I think this is one thing that people need to understand, that vascular malformations and hemangiomas are different.
Yes.
Vascular malformations are acquired or they form when the child is in the mother's womb, and they keep growing slowly in the womb and then after birth, and depending on rate of growth, they become visible at a particular age.
True.
So we see patients who have vascular malformations right at birth. We see so many children in the clinic.
Yes.
And then we see those who are in 30s and 40s and they suddenly notice some abnormality and come to us.
Yes.
So can you tell us what are the types of vascular malformations that we deal with?
I think they are basically what we see them broadly. We divide them into slow and high flow vascular malformations. It is more of a practical way of classification. The reason it is practical is because high flow vascular malformations most of the times require immediate attention, because they can cause problems either with increased flow or steal from the distal circulation. Like high flow AVMs can cause lower limb or upper limb ischemias, or in brain they can cause hemorrhage or stroke.
And even heart failure?
In a heart failure, in almost like in a fistula conditions where, like as you rightly mentioned, in newborn sometimes we get heart failure because of the vascular malformations in the liver or in the brain, like vein of Galen and all these things. And slow flow vascular malformations most of the times are insidious. They, at least in our practice, we see them most of the times coming with disfigurement related issues, like cosmetic related issues. Very rarely we see them actually causing physical symptoms. In some places where they are very close to the nerves, we may have neurogenic symptoms. Otherwise, most of the times it is cosmetic related issues. So broadly dividing in colloquial terms, venous, arteriovenous, lymphatic, or mixed. Like in some combinations we see them, or you can divide them based on the organs, like neural in origin in a brain or spinal cord, or in organ based like liver, heart. This is like a broad classification.
So from what I understand in terms of practical terms of management, what is important is the slow flow versus the high flow.
Absolutely.
So let's stick to this. And so if a patient has a slow flow vascular malformation, how do you diagnose it? What are the tests that you would do?
I think like how we do in our clinical practice day to day is, I think clinical diagnosis is the key here. Because the moment we diagnose it clinically, most of the times we stop it there. We don't have to do confirmatory tests in all the patients. just reassurance to the patient or the family is enough. And whenever we know that this is in a place where this may need further interventions or further treatment, I think initial test is always an ultrasound where it is accessible, like under the skin, in the muscle, or in the extremities, or even in solid organs like liver and spleen. Ultrasound is good enough most of the times. So for all practical purposes, anybody should know that a non-invasive imaging like ultrasound is the first modality that has to be used, and that actually gives us all the information, whether it is venous, only pure lymphatic, or a mixed picture. And in some cases where we think this may need further interventions, we do MRI. I think one thing which is important to understand in MRI is it is not necessarily a diagnostic test. It is more of a to see the extent of the vascular malformation. Very rarely we use it to diagnose the vascular malformation.
So we know it's a low flow vascular malformation, but to see the extent, we do one MRI. Now, some patients come to us with a CT scan. Is it really useful?
I think for practical purposes, it can cause a lot of confusion because CT scan is, a dynamic test, but it doesn't give us all the information that we need. And in spatial resolution, when it compared to the bone, skin, fat, MRI is far superior to CT scan.
So I think what we have seen in practice is a CT scan is good in some AV malformations, especially when it involves the head and neck.
Yes.
It can also show the bony erosions or bony deformities, if any. And there a CT scan has some real value, but not for a slow flow malformation.
And another thing, at least what we practice is, because in CT scan we have to give the dye, whereas in MRI, even though a lot of people do with IV contrast, gadolinium contrast,
we can manage without the dye.
It is not needed. So it is almost like non-invasive, we can call it.
Again, a very safe investigation. So MRI is the investigation of choice. Now, once we diagnose a low flow vascular malformation, what are the treatment options available to us for a patient?
Yeah, again, this is a very interesting thing because we practice this very regularly. And I'm sure you agree with me on this. Reassurance is probably the most important thing as far as the slow flow vascular malformations is concerned.
Yeah, I think typically we tell them that if it's in a limb, it is not going to, it's not risk for the limb, it's not risk for the life. It's more of a cosmetic issue at times. Patients who have pain or discomfort, or it's a large vascular malformation, what are the treatment options?
So first thing what we generally do in them is sclerotherapy. Depending on the location, the sclerotherapy can be a simple sclerotherapy with polidocanol or cetrol, and in some patients where we think the result is going to be very good, where repeat injections are not needed, we use absolute alcohol. And the difference in these two procedures is with alcohol we have to use a general anesthetic because that will cause a lot of pain during the procedure. So for that, most of the times we use general anesthesia. Very rarely we do it under deep sedation. The newer options that are available for us are what we call as best sclerotherapy now, which is quite encouraging because where some of the needles which are placed in the vascular malformation, which causes increased permeability of the sclerosant that is used. And in this scenario, we use bleomycin.
I see. So these needles, what is special about these needles?
So what we do here is they cause reversible electroporation.
So there is some sort of an external connection to them.
You need a hardware, a machine, which will cause electroporation in the tissues where we are injecting bleomycin, and it will increase the permeability so that number of sittings are reduced.
So it improves the efficacy of this sclerotherapy that we do. And of course, another thing that we've been doing is for very extensive malformations where none of these treatments is going to work. Surgery is not an option. Sclerotherapy is not going to work. we use immunosuppressive therapy or medical management,
Absolutely.
which brings down the size of these malformations,
yes.
bring down the pain and discomfort. Of course, that requires regular monitoring.
Sirolimus, I guess.
Sirolimus
You're talking
and
about.
especially for those ones which are, let's say, in the hand or very focal ones or limited to one area, surgical excision
Surgical
is a good
excision is
option.
very good. Yes.
Moving on to the high flow vascular malformations. How do we treat these?
I think these, I'm sure you agree with me on this, these are quite difficult to treat. And if patients are lucky, if there is only one communication between the artery and vein, and if surgery can be done, I think that is the best way forward. And unfortunately, most of them do not have just one communication. They have multiple communications where surgery is probably not that easy to do. And here we use what we call as embolization techniques. Again, I want to reiterate here, a lot of patients come with arteriovenous malformation diagnosis where they already have an angiogram. But you and I know very well that they're actually not arteriovenous malformations. They are slow flow venous malformation with some arterial supply to it. So these do not need embolization, whereas high flow vascular malformations, they need embolization. And we have various embolization techniques. We use coils if there is a simple fistula or a plug. And in some patients, we use absolute alcohol where we cannot reach the nidus of the arteriovenous malformation. And in other patients, we use what we call as glue, which is a thrombogenic agent which polymerizes when it comes in contact with blood. And in some patients, we use onyx, which is kind of a very slow polymerizing agent where predominant use is in the central nervous system where the critical areas are involved, where the precision is needed.
Yeah. So there are multiple embolizing agents, and depending on the area of the part of the body that we work in, the type of the vascular malformation, we would choose what embolic agent is best.
True.
And there are times when the AVM is not very widespread and reasonably localized, we can follow up with surgery. So embolize followed by surgery so that one gets a good cure. And again here, for extensive AVMs which are not very amenable to being controlled by embolization or surgery, again immunosuppressive therapy with sirolimus remains an option.
Yes, true.
So in conclusion, I think it's good to say that early detection is important, the right diagnosis is important, and the correct treatment, which sometimes means no treatment, is also very important.
Yes, that is very important, I think.
Yeah. Thank you, Dr. Pradeep.
Thank you.